Thank you all for joining today. I'm Dana Gress, Vice President of Clinical Services for Genoa Healthcare. We are excited to continue on our educational series for Lunch and Learns to help support our clinical program specialists as well as our clinic partners. So again, thanks today. Today's topic is whole person care for behavioral health needs and family caregiver support. And I am going to kick it over to your lead presentation team today. First is Shannon Thompson, and Shannon's going to give a brief overview of herself, and then she'll pass it over to Lisa Sutton.
Excellent. Thank you for the introduction. Hello, everyone. My name is Shannon Thompson. I am a pharmacist by trade. I currently serve as the Program Design and Implementation Specialist here at Genoa Healthcare. Pleased to be with you today to kick off our third monthly educational series presentation. I'll hand it over to Lisa to do her intro, and then we'll kick us off.
Hi, everyone. My name is Lisa Sutton. I am one of the clinical pharmacy managers with the Genoa Healthcare Clinical Services team. I've been with the company for about 4 years. Lots of experience as a retail pharmacist, but the last 10-ish years of my career have been in the managed care space. So excited to work with you all today and discuss these topics. Thank you.
Great. Sounds great. So our presentation today will cover two crucial topics. So the first of which is going to cover whole person care for behavioral health needs. By focusing on the whole person, healthcare providers can offer a more personalized and effective care, ultimately leading to better health and well-being for individuals. Our objectives today will be to define serious mental illness, or SMI, and its common morbidities, highlight the unique healthcare challenges for individuals with SMI, especially those with co-occurring physical conditions. We will also outline evidence-based strategies to improve both mental and physical health in SMI management. We will summarize emerging pharmacologic treatment for diabetes and obesity in individuals with SMI. And finally, identify integrated and collaborative care models that enhance healthcare delivery for this population. Serious mental illness, or SMI, refers to diagnosable mental, behavioral, and emotional disorders that cause significant functional impairment, substantially interfering with or limiting one or more major life activities. Common diagnoses include conditions such as schizophrenia, bipolar disorder, and severe major depressive disorder. Approximately 22.8% of adults, which is just shy of 60 million adults, in the US have experienced mental illness, with the most affected age group being young adults with a prevalence rate of almost 40%. An estimated 5.7% of adults in the US have a serious mental illness. Individuals with SMI face a 15 to 25-year mortality gap compared to the general population, highlighting the severe impact on life expectancy. Cardiovascular disease is the leading cause of death, both overall and specifically for patients with schizophrenia. Those with schizophrenia have a 3-fold increased risk of all-cause mortality compared to the general population. Additionally, those with SMI are more likely to have obesity and diabetes than the general population, contributing to their overall health burden. Of note, metabolic dysregulation is often apparent early in the detection of mental illness, indicating the need for early intervention and monitoring. Obesity is a risk factor for depression. This creates a cycle of both physical and mental health challenges. And many mental health medications can cause cardiometabolic problems, necessitating careful management and monitoring of patients' physical health. There are many challenges that those with SMI face, one of which is psychiatry provider engagement. There may be stigma and misunderstanding, resource constraints, as well as communication barriers. There's also prioritization of behavioral health. There could be systemic bias, which is prioritization of physical health over mental health or vice versa, as well as lack of integrated care. or separation of health services can result in poor health outcomes. There may also be inadequate training or lack of comfort. Some providers may feel that they have insufficient education or limited training in behavioral health. There may also be a fear of complexity where providers may feel unprepared to handle them. There are some individuals that only seek behavioral health treatment. This may be due to lack of awareness. They may not understand that physical health alongside mental health is also important. There may also be accessibility issues where behavioral health services may be more accessible than general health services, leading to that imbalance of care. Finally, there's a possibility of fragmentation of care. This could include disjointed services where behavioral health and physical health often are provided separately, which could cause gaps in care, as well as coordination challenges where there's poor coordination between different providers that can result in inconsistent and ineffective treatment. These challenges highlight the need for integrated, comprehensive care approaches to better support individuals with SMI. Primary, secondary, and tertiary prevention are all crucial in treating individuals with serious mental illness because they address different stages of disease progression and help ensure comprehensive care. Here's how each level contributes. Primary prevention is where the goal is to prevent the onset of SMI. This includes education and awareness and encourages early help-seeking behaviors. It also encompasses risk factor reduction, such as addressing factors like stress, trauma, or substance abuse, as these can reduce the likelihood of developing SMI. Then we have secondary prevention, where the goal is to detect and treat SMI early. This includes screening and early diagnosis, as regular health screenings can identify SMI in early stages and allow for timely intervention. This also encompasses prompt treatment, where early treatment can prevent the progression of SMI and reduce the severity of symptoms. We finally have tertiary prevention, where the goal is to manage and reduce the impact of established SMI by utilizing high-quality integrated care. This includes ongoing treatment and rehabilitation, including medication management and therapy, as they help to manage symptoms and improve quality of life, as well as support services like social integration, support for daily living, and vocational training, as these can help those with SMI lead fulfilling lives. By integrating these three phases of prevention, healthcare systems can offer a more holistic approach to managing SMI, addressing both the prevention of new cases and the effective treatment of existing ones. This comprehensive strategy helps improve overall outcomes and quality of life for individuals with SMI. Listed here are the key targets to help manage in folks with SMI. The first is access to a primary care provider. Physical health monitoring goes hand in hand with behavioral health care, as those with SMI are at greater risk for various physical health conditions. There's also management of weight. Under the best circumstances, diet and exercise leads to an average of 5 to 10% weight loss. It's also important to review obesogenic medications, including anticonvulsants, antidepressants, and antipsychotics. We know that antipsychotics can cause weight gain because they block dopamine signaling in the brain and the pancreas, which can lead to uncontrolled production of blood glucose-relating hormones. There was a new drug released in October of last year called Cobenfy that can be an option for patients. This medication does not block the dopamine 2 receptor, but instead combines xanolamine and trospium to minimize the peripheral side effects of the medication. There's also smoking cessation. This is important as it's addressed in the EAGLES study. This is a global smoking cessation study that evaluated adverse events. The study showed that abstinence rates were greatest with varenicline, which is the generic for Chantix, followed by nicotine patch or bupropion or Wellbutrin, followed by placebo. Additional studies have also suggested that long-term maintenance treatment may facilitate sustained abstinence. Vaccines are also a key target, as some individuals have significant hesitancy toward vaccines and don't include them in their health regimen. And finally, there's also reduction of cardiovascular disease risk. The Physical Activity Vital Sign, or PAVS tool, can be used. This is an assessment tool designed specifically to address physical activity and assess physical activity in primary care settings. It uses 2 questions to determine if patients meet the recommended 150 minutes of moderate physical activity per week. PAVS data from schizophrenia patients show that only 39% of those meet the physical activity requirements, and less active patients had a 1.7 times higher risk for hypertension and a 3 times higher risk for developing metabolic syndrome. Presented here is a list of new pharmacologic interventions in the form of GLP-1 receptor agonists, as well as the GIP GLP-1 co-agonists for type 2 diabetes. We first have exenatide, which is marketed as the short-acting version, which is Byetta. There's also a long-acting version called Bydureon. Both of these are available in the form of a subcutaneous injection. We also have liraglutide, which is marketed as Victoza. There was a 16-week study of placebo versus liraglutide up to 1.8 milligrams per day in patients with prediabetes that were receiving either clozapine or olanzapine. The study found that patients receiving liraglutide had improved glucose tolerance, reductions in waist circumference, as well as an average of a 5.3 kilogram weight loss versus placebo. We also have dulaglutide, which is marketed as Trulicity, an option for patients. And then we have semaglutide, which is marketed in the long-acting injectable forms of Ozempic and Wegovy. There's also an oral version of semaglutide, which is marketed as Rybelsus. There was a case series of 12 patients receiving various antipsychotics who experienced failure on metformin, and they were given semaglutide up to 2 milligrams per week. The weight loss outcomes after 3 months on therapy was an average of 4.6 kilograms. At 6 months, it was 5.2 kilograms, and then at 12 months, it was an average of 8.7 kilograms weight loss. There's also been some emerging evidence that Wegovy may offer benefits across various mental health conditions, including reducing cravings for substances and improving mood. And finally, there's also the option of tirzepatide, which is marketed as both Zepbound and Mounjaro. All right, and we have made it to our first poll question to test your knowledge. Which GLP-1 medication has shown potential benefits in reducing cravings for substances and improving mood in patients with behavioral health conditions? We have A, exenatide, B, semaglutide, C, liraglutide, or D, dulaglutide. And if you're able and want to submit your answers in the chat, we'll give everybody a couple seconds to test our knowledge. All right, we've got 1 vote for B. Let's see if anyone else is able to chime in. All right, quiet in the chat today. That's okay. Well, congratulations. The correct answer is B, semaglutide. So this question highlights the emerging evidence that Wegovy, the specific version of semaglutide, for those kind of benefits across those mental health conditions, including the reduction of cravings for substances and improving mood. All right, moving to our final objective for this particular topic. This is the continuum of integration of care. So this refers to the various levels and stages at which healthcare services can be integrated to provide comprehensive, coordinated, and patient-centered care. This continuum ranges from minimal coordination to fully integrated systems. So here are the key stages. First, we have coordinated care. This takes place off-site and is where medical care is managed by psychiatrists, health navigators, and case managers. There is prescribing of medications, screening for metabolic concerns and conditions, counseling on lifestyle changes, as well as management of common medical conditions. This structure has minimal collaboration as patients are typically referred to their primary care provider at another site, oftentimes with limited communication. Next, we have co-located care, which occurs on site. This operates through facilitated referrals where there's a communication about care plans, providers, and sharing of medical records. This type of care exhibits a moderate level of collaboration as providers are located within the same physical site, but there may or may not be sharing of medical records and treatment plans within this particular model. Finally, we have the integrated care model. This also occurs on site and offers fully integrated primary care services, specifically medical services. Here, the providers plan and implement care plans for all patients. And in some cases, there's a dually boarded physician that manages both medical and psychiatric conditions. So understanding and implementing the continuum of integration of care can significantly improve the quality and effectiveness of healthcare for individuals with SMI. So this takes us back to those three approaches that we reviewed earlier: primary, secondary, and tertiary prevention. So if you remember, tertiary prevention refers to that high quality integrated care, which is the perfect lead into collaborative care and its approaches. Collaborative care encourages multi-professional work between the primary care provider and at least one other service. It's a structured management plan in the form of protocols and/or guidance. And this approach includes scheduled patient follow-ups as well as enhanced interprofessional communication. Patients benefit from their medical and behavioral health providers working together as a team to provide effective whole person care. Patients in integrated settings have higher satisfaction with their behavioral health and their treatment. Both integrated care and collaborative care aim to improve health outcomes by ensuring that patients receive comprehensive, coordinated, and patient-centered care. Understanding these differences can help healthcare providers choose the best approach for their practice and patient population. The integrated care model provides care for medical and behavioral health conditions, uses a holistic approach, is team-based, and occurs at various settings. Collaborative care is a specific model for implementing integrated care, uses core principles to drive success, utilizes care managers, and typically occurs within one shared setting. So this brings us to our next poll question to check our knowledge. In the collaborative care model, which healthcare professional typically plays a key role in coordinating care and ensuring that treatment plans are followed? Is it A, the primary care provider, B, the psychiatrist, C, the care manager, or D, the social worker? All right, we've got an A. Let's see if anybody else wants to chime in the chat. All right, very good. Well, the answer to this poll question is actually C. The primary care provider is actually part of both care models, but what separates the collaborative care model is really the resource of using the care manager. So this question just is meant to emphasize that critical role of care managers within that collaborative care model, where they help to coordinate that care and make sure that the patients are receiving consistent and effective treatment. All right, we will now change gears and switch over to our next topic, which is that of family caregiver support. So I will turn it back over to Lisa.
Thank you, Shannon. All right, so our next topic is family caregiver support, and I want to kind of touch on why this is so important first. So remember that a family caregiver is an unpaid person who provides support and assistance to a family member or a friend who is in need due to illness or disability or aging. So these folks are not Their job is not to be a caregiver typically. They are just stepping in to provide care for someone that they care deeply about. We've learned that better supporting family caregivers can lead to several positive outcomes, including improved patient outcomes like more effective care, better adherence to treatment plans, but we also see things like reduced hospital readmissions, enhanced quality of life, lower healthcare costs, increased care continuity, reduced caregiver burnout, and improved communication. So this is super important. So today we're going to go through the following objectives. We're going to learn the roles of a caregiver, identify challenges of caregiver experience, establish strategies to support the caregiver, understand motivation and intrinsic value of the caregiving role, and then review some different resources that you may use yourself or pass on to family caregivers when you have any interactions with them. So first we'll talk about the roles of a caregiver. As I mentioned before, these family caregivers may be taking on responsibilities that they have no experience with in the past. For example, physical care. Many people have had experience caring for small children at some point, and they often assume that caring for an adult will be the same, which is not necessarily true. Lifting and moving their loved one, using and cleaning bedpans, those are all very different from what they may have experience with in caring for small children in their families. We're also looking at things like preventing bed sores, bathing, and needing to do that sometimes waterless, oral hygiene. These are all additional aspects of physical care that may be completely new to a family caregiver. Providing emotional support to a loved one experiencing health concerns is another important role of the caregiver. In addition to coordinating home and community support services, oftentimes the family caregiver is already doing this for their own immediate family. For example, a spouse and their children, if they have children still at home. And taking it on for their loved one is just an added responsibility. They're willing to do it, but it is sometimes a burden. This can also be true for coordinating healthcare, assisting with emergencies, various household tasks, and personal tasks. So it's often on top of what they're already doing for their own family. As you can imagine, this can create some serious challenges for the family caregiver. They may feel unprepared to take on these responsibilities, leading to stress and strain in their own life, which could lead to things like sleep disruption, and decreased health overall. They may also take on financial responsibilities, leading to their own financial strains, just trying to help out. They may feel guilt they may feel guilt that they're not doing enough for their loved one, maybe feeling unprepared, or they may also feel guilt about sacrificing time with their immediate family. If they're married or if they still have children in the home to care for their loved one. This can lead to changes in family dynamics. Perhaps one spouse has to take on additional responsibilities at home because the other is spending time providing care. And that in itself could cause some strain on that relationship. So balancing all of these responsibilities and working through the challenges can take a toll on the caregiver's overall well-being, which is something that we need to be aware of. The good news. Next slide, Shannon. The good news is that caregiver support is on the rise. Now that we know that providing support for family caregivers can drastically improve outcomes, we're seeing a lot of different organizations putting out information out there. So we've learned to not only recognize all of the caregiver roles and challenges, but there's an increasing amount of support and education available for those caregivers. When a caregiver first makes the commitment to providing care, the preparedness for caregiving scale is a self-rated instrument that you can use or that you can pass along to the family caregiver. It has 8 different items that asks caregivers how well prepared they are for caregiving or how well prepared they feel they are. This evaluates preparedness for providing physical care, emotional support, setting up in-home support services, and dealing with the stress of caregiving. Essentially, the higher the score, the more prepared the caregiver feels. And this screening tool is recommended in clinical practice, mostly as a way to help caregivers identify which areas they may need additional support in. So maybe they're really strong in one area, but feeling unprepared in another. And um, that's where healthcare professionals and anyone coordinating care with these family givers can target education wherever it's needed. So we can both assess preparedness and determine what resources are available for the caregiver to become more prepared. Additionally, we're seeing federal programs focusing on creating and managing policy to protect and support caregivers and their loved ones. The National Council on Aging and other organizations advocate for transition of care programs where caregivers and patients are provided support during the transition from hospital to home. To help with financial challenges for the caregiver, different states have various policies, but there are some things like paid family leave programs, and some caregivers may even be eligible for Social Security benefits while providing care for their loved one. I didn't want to get into too much detail with that because it does vary by state, but just know that there are policies in existence to help. All right, next slide, Shannon. Communication essentials. So one very important aspect to supporting the caregiver is communication. So not only when we're communicating with the family caregiver, but also some tips and tricks to provide that family caregiver when they're communicating with their care recipient. So here are a few do's and don'ts to keep in mind when communicating with them and the patient that they're caring for. You want to make sure that you're calling the patient and the caregiver by name. That lets them know immediately that you are supporting them and that you are a resource, a trusted resource for them. Listen. Make sure that you're listening to what they're telling you. They are going to share their concerns and share where they need your support. One thought at a time. This can be a very overwhelming time for both the caregiver and the care recipient. Using an appropriate tone of voice so that nobody feels like they're being talked down to. You want to make sure you keep a very supportive environment. Acknowledging feelings. There will be a lot of overwhelm, sometimes fear and uncertainty. So you want to acknowledge them and their feelings and let them know that you're here to help. And just encouraging them, with some support, you'll be able to do this, and we're here to help. You always want to avoid defining someone by a medical diagnosis. Don't want to refer to them as handicapped or diabetic or arthritic. And you also want to avoid negative references. So you don't want to say that they suffer from blank or they're a victim of blank or that they're confined to a wheelchair. That may be our perception of things, but that may not be their perception of things. So we just want to make sure we're being respectful of that. All right, so here are some strategies. Caregiver well-being is something that can decline very, very quickly, something that we need to be on the lookout for. And we can encourage caregiver well-being by encouraging the caregiver to do these things: be active, eat well, prioritize sleep, reduce stress, make time to relax, keep up with your own health, take a break if needed, be kind to yourself, and ask others for help. Now, I know that I would love to prioritize all of these things, but this list can also be overwhelming. So it's really important to make sure that you're considering the family caregiver that you're dealing with and identify where they where they could benefit. And we'll talk a little bit more about these coming up here, but first we're going to check your knowledge. So get ready with your typing fingers in the chat. What is an effective strategy to maintaining the caregiver's overall well-being? A, eat well. B, keep up with your own health. C, ask others for help. Or D, all of the above. Excellent. D, yes. Correct answer, everybody. We want to ask our caregivers to do all of those things. I know I am not a family caregiver for anyone. I mean, I have children, but I'm not providing extra care for an adult family member who needs it. But it is still hard for me to prioritize my self-care. And so you will probably hear pushback from family caregivers who say things like, oh, geez, I've forgotten what self-care is, or I just don't have time for that. Um, and it's very easy for us as onlookers to just list off all of these ways that a family caregiver can ensure their well-being. But it is so much easier said than done. So what we really need to do is help them identify a list of doable things, things, small wins, things that they can really accomplish so that they really feel that immediate sense of accomplishment and that contribution towards self-care. So even if it's like 5 minutes to stretch or scheduling a 10-minute video chat with a friend, that's a very low time commitment, but something that can really maximize their self-care and their feeling of self-care. They may also express feelings of guilt, saying things like, well, my family needs me, or, and I can't worry about myself, or self-care is selfish. I need to be focused on my loved one. But it's really important to validate that they are only able to care for others if they are also being taken care of, that their own needs are met. And they may need to hear that validation that self-care is not only okay, but it truly is necessary. Everyone needs to be focused on self-care before you can focus on care for others. All right, next slide, Shannon. So family caregivers step into this new role of caregiving for many different reasons. Most often, they're primarily motivated by love or a general desire to reciprocate past care or support. For example, it's their mother, and their mother cared for them as a child, and now they feel this need to care for their mother right back. But that feeling of motivation and that root of motivation can sometimes change through the family care process. So there are many factors that we can help with to promote continued motivation for these family caregivers. So autonomy is the first one, and there's kind of two parts to this autonomy. Caregivers, number one, need to feel like they had a choice in making the decision to provide care. If they feel forced into it, they will resent this decision that they made. So kind of assessing that for the family caregiver is one way that you can help to support them right off the bat. Their motivation may be very low if they feel like they haven't, that they weren't in part of this decision-making process. And then once we get past that point, by encouraging the family caregiver to take part in making choices and planning for the future of their loved one, they tend to experience higher quality motivation and reduced burden. So making sure that they are part of the process all along can really help there. Similarly, when the family caregiver is prepared and educated for their new role, they have greater competence. This boosts their confidence and supports caregiver well-being, which again leads to higher motivation. Relatedness refers to the feeling of support from other families who are in a similar caregiving or care receiving situation. So finding other folks who are going through the same situation can be really helpful through a support group or just relating to friends in their community. This feeling of shared experience and purpose can really foster a positive caregiving experience and reduce feelings of isolation and burden. Mutuality, where both individuals feel a sense of connection and support, can contribute to a positive caregiving experience. So this is where both the care recipient and the caregiver feel like they're helping each other. They're there for each other. There's no resentment. It's a mutual decision that they're taking part in, and this also increases the motivation and quality of care. Um, there are two types of motivation. I already mentioned that primarily folks step into the family caregiving role out of love. This is what is called an intrinsic motivation. So this just comes from the desire to provide care. It's based out of love, empathy, or a sense of purpose. But there's also an extrinsic motivation, which is like an obligation, where you just feel like, oh, well, society expects me to take care of my mom, or society expects me to take care of my dad when they're sick. That is not always the most what's the word I'm looking for? Effective motivation or source of motivation for family caregivers. Extrinsic motivation can be fueled by just social expectations or the feeling of obligation to provide care, like I mentioned. So ideally, we want family caregivers to be motivated by intrinsic motivation. This is associated with greater satisfaction and well-being in the long run. How can we help with that? Well, it has been shown that support from healthcare professionals and then any additional family members who are stepping into a partial caregiver support role can positively influence intrinsic motivation to care, therefore leads to more positive outcomes for the caregiver and the care recipient. So our support leads to their intrinsic motivation and overall better care for the patient. All right, we're going to move on to the next check your knowledge. So, true or false? Intrinsically motivated behaviors tend to be more sustainable over time. True or false? True. Yes, Kim. Yes, Shannon. True. Intrinsically motivations or motivated behaviors do tend to be more sustainable over time. They're associated with better well-being for the caregiver and better outcomes for the patient. So great job there. All right, so the next slide here is probably the most important, but these are resources that are very helpful for anyone who may have connections with a family caregiver in the healthcare realm. So you can find resources for yourself here, or you can you can provide these resources to family caregivers as well. You notice there's one for Alzheimer's. So for anyone specifically looking for support with Alzheimer's caregiving, you could navigate yourself there. But everything on these websites here is very patient friendly and really good information. So just a great way to provide that support and let caregivers and their care recipients know that they are not alone. All right, thank you for your time and attention today. Shannon and I are happy to answer questions that you may have at this time. So go ahead and type those into the chat.
Yeah, perfect. And while we're waiting for any questions, I did want to call out that today's presentation recording is going to be placed on our Genoa's YouTube channel. That is accessible through the link posted on this slide, which is www.genoahealthcare.com/center partner resources. All of our previous presentation recordings are posted here as well, and the registration links for our upcoming presentations are also housed here. Our next presentation is going to be held on Friday, July 18th at 12:30 p.m. Eastern. The topic of our next presentation is the foundational elements of health equity in the healthcare setting and social determinants of health, as well as their impact on care. We will have that link for our next presentation in July up on this website within the next week or two, so please check back for your link to register. All right, awesome. Very good. Well, if anything comes up, feel free to reach out to Lisa or I directly via email or through Teams. But we thank you for your attendance and hope you guys have a great rest of your afternoon and a great weekend.